Society of Blood and Marrow Transplantation. I am Dr. Abdullah Al-Saleh, an assistant professor at King Saud bin Abdulaziz University for Health Sciences and a hematologist at King Abdulaziz Medical City in Riyadh, Saudi Arabia. We would like to thank the sponsors for this educational event. As we know all, chimeric antigen receptor T cell therapy, also known as CAR T, is a promising new technique to treat cancer. It's currently approved for the treatment of relapsed and or refractory diffuse large B-cell lymphoma, as well as mantle cell lymphoma. And many ongoing trials are evaluating this therapy for other malignant hematological conditions. Today, we are lucky to have Dr. Mehdi Hamadani to give us an update about CAR T therapy, its current status, and future. Dr. Hamadani is a full professor of medicine and the director of adult BMT and cellular therapy program at the Medical College of Wisconsin. Dr. Hamadani is an expert in the field of BMT and cellular therapy with the main interest in research and clinical trials. He has more than 200 published research, including clinical trials, prospective, as well as retrospective studies. Currently, he's the principal investigator of many clinical trials, and he's a member of the editorial board of many known journals with high impact factors such as the bone marrow transplant, clinical lymphoma, myeloma, and leukemia, as well as the American Journal of Blood Research. Dr. Hamadani has also participated in writing many book chapters, mainly on stem cell transplant. He is currently the co-chair for the ASTCT Committee on Practice Guidelines. He was also the chair for the ASH Friday Satellite Symposia Study Section. He was the editor-in-chief for the ASH News Daily. We would like to thank you, Dr. Hamadani, for your time and effort today and giving us this presentation. And I leave the mic to you, Dr. Hamadani.
Oh, thank you very much. This was very kind introduction, Dr. Al-Saleh, and I thank the Saudi Society for Blood and Marrow Transplantation and Dr. Al-Saleh for your kind invite. Assalamu alaikum to everybody in Saudi Arabia. So I'm going to start by sharing my screen. It may just take me a quick second. So today I have been asked to discuss the role of chimeric antigen receptor modified T cell therapy in lymphomas, sort of go over the current literature to orient myself and orient the kind audience. And then we will talk about where the field might be moving in the next few years. And then obviously it's not a perfect therapy. So whenever we talk about benefits of a therapy, we also have to think about what are the problems associated with therapy and potential research areas where those things could be improved. These are my disclosures. None of these are relevant to the talk, but for the sake of full transparencies, these are listed here. So aggressive lymphomas for people who see hematological malignancies, people like you, are not uncommon disorders. They may be rare diseases, but diffuse large B-cell lymphoma is the most common aggressive lymphoma we see. I was talking to the Pakistani Medical Oncology Society last night, where I was mentioning that aggressive lymphoma is an interesting disease. You get 4 chances to cure it. Half of the patients are cured by frontline rituximab-based therapies. And even if patients who relapse, now we have 3 chances to cure these patients. We can cure these patients with an autologous transplant. We can cure them in the past with an allo transplant. And more recently, we will be talking about how chimeric antigen receptor T cells is modifying our practice. Now, this is a survival curve of what happens to typical aggressive lymphoma patients if they are refractory to treatment. And the way refractoriness was defined in this study was anybody who got at least 4 cycles of R-CHOP and they were not responding, meaning they didn't even achieve a partial remission, was called refractory disease. or patients who relapsed and then they were getting salvage therapy, maybe something like DHAP or RICE, and after 2 cycles, they were not responding to the treatment. So once aggressive lymphoma becomes refractory, you can pretty much appreciate from this curve is that vast majority of those patients don't do well. It's a challenging group of patients. Historically, once you develop refractory disease, no more than a quarter of these patients will respond to the next line of treatment. And the median survival of these patients is well under 1 year. So that is definitely what we considered an area of great unmet need a few years ago. And it is still an area of unmet need, uh, but the availability of immune T cell redirecting therapies have improved our ability to manage these patients. Now, CAR T cells is obviously not the only modality available, but that's certainly the topic today. Now, why are CAR T cells important? So in this cartoon shown here, we all know that T cells have many important functions in immunity and tumor surveillance. But normal T cells tumor recognition depends on antigen recognition in the context of an MHC molecule, which is a limitation. So our T cells in our body are always surveilling for immune system for different cancers. But for them to recognize the cancer, a part of cancer antigen needs to be processed within the cell and then needs to be presented on the surface of the cell shown in the left here along with the MHC molecule. Now, the chimeric antigen receptor modified T cells is a very clever way of bypassing this system. In a chimeric antigen receptor modified T cell, the T cells through retroviral or lentiviral transduction are reprogrammed to now directly express a receptor that directly recognizes an antigen on the tumor cells without the requirement of antigen presentation in the context of the MHC molecule shown on the right here. Now, chimeric antigen receptor modified T cells is really not a very new concept. To my knowledge, the very first basic science studies looking at this principle were published in actually late 1980s. And the clinical trials looking at these strategies in Penn and NCI have been going on for about 20 years now. And these chimeric antigen receptor modified T cells have gone over certain modifications. So the very first chimeric antigen receptor modified T cells only expressed the antigen recognizing or tumor antigen recognizing domain on the surface, the so-called SCFV portion, but they didn't have any co-stimulatory molecules. So these chimeric antigen receptor modified first generation products had problem with persistence and efficacy as well. The second generation CARs modified the construct by adding a co-stimulatory molecules, and in the commercially available products, the Yescarta product has a CD28 co-stimulatory domain, and the Kymriah product has a 41BB co-stimulatory domain, and we will talk about what clinical implications these different co-stimulatory domains are, but these improved the activity of these CARs and perhaps the persistence of these CARs as well. And second generation is where the commercially available platforms are right now listing. And there are obviously concepts of third generation CARs where you add more than one co-stimulatory domain, and then there are trucks coming down the road. And truck is the concept is where you conjugate the CAR molecule with the complete T cell receptor, and those technologies have certain advantages that we can talk about in the Q&A portion. So clinically right now we are at the second generation where the CAR molecule or the CAR cell on the surface recognizes one tumor antigen And inside the cell, it has one co-stimulatory domain, either CD28 or 41BB. Now, how do CARs work? I'm sure the group is familiar with the mechanics of how at least a commercial CAR product works. So once we recognize or identify a patient who requires CAR T cell therapy, they first undergo apheresis, which is very similar to apheresis for stem cell collection with some programming differences. Instead of collecting stem cells, we collect white blood cells or lymphocytes. These lymphocytes are shipped off to a central GMP facility where these cells are transfected by either a lentivirus or a retrovirus carrying the program, so to say, for the chimeric antigen receptor. And once these T cells are co-stimulated and transfected, the generated CAR T cells are brought back to the CAR centers. And typically after giving lymphodepletion with fludarabine and cyclophosphamide, which you can call something very similar to reduced intensity conditioning we give to lymphoma patients, these chimeric antigen T cells are infused. Now the question is, why has this field focused so much on CD19? Why didn't the field focus on CD20? And CD19 clearly had certain advantages. So CD19 has broader expression on B-cell malignancies. It is uniformly expressed on ALLs. CD20 expression, as you know, is hit and a miss on ALL patients depending on how mature the ALL patient is. CD19 has consistent expression on all lymphomas, and even it goes on to patients with lymphoplasmacytic malignancies like Waldenstrom's macroglobulinemia. And most people, including me, I don't believe CD19 is expressed on hematopoietic stem cells. So there is an advantage that it may not have myelosuppressive properties, which is clinically not true. Um, so that was the story behind why CD19 was targeted. And the other reason was when CARs were being developed, Rituxan was already standard of care, and there were concerns that a CD20 directed CAR may not be efficacious in patients who are starting to fail CD20 directed treatments. So where does the field rests now? So I'm sure the group is familiar with the data of ZUMA-1, but I still think the ZUMA-1 trial are very important data because that basically got the first CAR product approved in patients with hematological malignancies. So the ZUMA-2 trial looked at aggressive B-cell lymphoma patients, and it had two independent cohorts. Cohort number one was patients with typical diffuse large B-cell lymphomas with or without c-Myc gene rearrangements, and cohort two was patients with primary mediastinal or the thymic large cell lymphomas or indolent follicular lymphoma that has transformed into follicular lymphoma. So there were 20 patients in the second group, 72 patients in the typical diffuse large B-cell lymphoma group. And the eligibility was patients who had failed at least 2 prior lines of therapy. So on this trial, overall, about 100 patients were enrolled, and these patients had age up to the age of mid 70s. The median age was late 50s, but about 25% of patients were above the age of 65, and this treatment is very feasible in older patients. These patients had advanced stage disease. About 70% of these patients had failed 3 prior lines of chemotherapies or chemoimmunotherapies. And a number of these patients were refractory to the last line of therapy. So remember the Scholar 1 curve I showed you in the beginning, that patients who are refractory, their odds of responding to the next line of treatment historically were about 25%, and their median survival was about 6.5 months. And CARs clearly had very high evidence of activity in this very challenging patient population. So in diffuse large B-cell lymphoma, the complete remission rates were about 50%. In sort of indolent lymphoma transforming to large B cells or thymic lymphomas, the response rates were above 70%. And these data are obviously well known. Now, how did the next question is, if patients are responding, how durable are the response rates? So this is some long-term follow-up data from the ZUMA-1 trial. So remember, ZUMA-1 trial's original publication was in New England Journal of Medicine in 2017, but in 2019, Fred Locke from Moffitt updated their long-term outcomes, and they look uh, impressive. So among patients, and not everybody you want to give CAR can get CAR, because there are a small subset of patients who have such aggressive disease that they die before you can figure out all the logistics of CAR T cell administration. But at least among patients who got the CAR infusion, their progression-free survival at 2 years is about 40%. So it's an important number to keep in mind. So among patients who are able to get the CAR infusion, you're probably going to cure about 40% of those patients, which is, like, not as high as it was advertised, but it's a remarkable activity of this powerful immunotherapy. So based on these data, in October of 2018, uh, Axicell or Yescarta was approved for patients with relapsed aggressive lymphomas among patients who were not responding to at least 2 prior lines of therapy, including transformed follicular lymphoma and primary mediastinal large B-cell lymphomas. And again, these curves continue to show that there is definitely a subgroup of patients who are long-term survivors. Now, CAR treatment, while very feasible, um, comes with a degree of um, toxicity. Um, so after administration of CAR T cells, we worry about 3 toxicities, and I'm going to talk about two. Um, the two major toxicities we worry about is the cytokine release syndrome, where patients typically present with fevers. And if you're talking about the Yescarta or the Axicell platform, that typically happens within first 3 days of infusion. So the median time to the onset of CRS is about 3 days. And the severe CRS or grade 3 or higher CRS is about 20% with this product. Um, and then the second toxicity we worry about is the neurotoxicity, where patients can develop confusion, they get disoriented, they have word finding difficulties, their orientation is affected. While seizures and coma and even death have been reported, grade 5 toxicity is uncommon, but it can happen. Um, so in our experience, you know, patients who develop CRS, we commonly use tocilizumab. And in the coming sections, we'll talk about some data about maybe preemptively using tocilizumab to reduce uh, the effects of CRS. But generally, in our institution, we have treated over 150 CAR patients, and we don't have a single patient who passed away or died because of either neurotoxicity or CRS. Uh, but the third complication, which is perhaps the most challenging complication, is an HLH-like picture. And in the ZUMA trial, there was at least one case of HLH patient that passed away because of that complication. And even in our center, we recently had a patient with HLH that we tried to treat with tocilizumab and anakinra, but we were not able to reverse the course of that patient. So yeah, at our site, that is the only non-relapse or treatment-related mortality of CAR, and it was primarily driven through um, HLH or hemophagocytic lymphohistiocytosis, and it's an immune complication where, because of perhaps macrophage activation, you see profound cytopenias and a very full-blown picture of a typical HLH case. And if somebody has questions about it, we can perhaps talk a little bit more about it in the Q&A portion. So now the main limitation of CAR T cell therapies is that we don't have any randomized data compared to other available therapies. Are CAR T cells improving outcomes? So when you don't have prospective randomized data, then we rely on certain retrospective comparisons. So this was a nice uh, retrospective comparison. So in this retrospective comparison, patients on ZUMA trial were matched with patients on the Scholar 1 study, the study I showed you in the very beginning of refractory lymphoma patients. And these patients were matched uh, based on their level of chemorefractoriness using a propensity score weighted analysis. And at least with all the limitations of a retrospective propensity score matching, there appears to be a survival benefit with cell therapies compared to best available care um, and historical controls. Now, clearly, ZUMA or XeCell is not the only CAR cell therapy out there. Um, just by coincidence, right, last night the US FDA approved Lysocell, which is the third CAR platform shown here at the very bottom row. So in USA, as of today, there are three CAR platforms that are commercially approved. The very first approval in October of 2017 was XeCell based on the ZUMA trial data I showed you in detail here. For the sake of time, we obviously can't go into the details of every single trial. The middle row here is the Tizacell data or the Kymriah data, and the bottom row is the approval last night of the Lysocell data. Uh, but I just wanted to show you some similarities across these products. So all of these products use the same lymphodepletion uh, platform of fludarabine cyclophosphamide with 2 days of rest. In our center, we are using 1 day of rest. There is no biological reason to do 2 days of rest after flu-cy. XeCell uses a CD28 co-stimulatory domain. Both Tizacell and Lysocell use 4-1BB. And that perhaps reflects in the toxicity differences of these products. So we believe that you see more CRS and especially more neurotoxicity with CD28 co-stimulatory domains. And if you compare these products, the rates of neurotoxicity are highest with XSL, and they appear to be lowest with the more recently approved Juno CAR or the Lysocell product. So in USA, because of the way insurance reimbursements work, we want a product that we can infuse on an outpatient basis. And at least in my opinion, XeCell is not an easy card to infuse on outpatient basis. So we have experience with infusing Kymriah on outpatient basis, and I think Lysocell is also very practical product to infuse on an outpatient basis. Now, how CARs have impacted our practice is shown here. So I'm showing the use of allotransplant for various cancers or various lymphomas, and these numbers since 2017 are actually going down. But the only product that is shooting up is uh, use of CAR T cells for diffuse large B-cell lymphoma. And it just shows you the profound impact CAR T cells have on the management of patients with relapse lymphomas. Now, obviously, CAR T cells are not only being used in diffuse large B-cell lymphoma. In July of last year, CAR T cells were approved in patients with mantle cell lymphoma based on the ZUMA-2 trial. Now, ZUMA-2 uses, uh, again, a CD19 CAR, which is called X19 or Tecartus. It is very similar to Yescarta. It's in fact Yescarta. The only difference between Yescarta and the X19 CAR is that during CAR manufacturing, uh, you do T cell enrichment, because the problem with mantle cell lymphoma is mantle cell lymphoma can circulate in the blood. So theoretically, you can have tumor contamination um, in your apheresis product. So to address that concern, Tecartus manufacturing involves selecting T cells, basically getting rid of the circulating lymphoma cells, but the rest of the platform is very identical to Yescarta. The ZUMA-2 trial enrolled mantle cell lymphoma patients who received up to 5 prior lines of therapy, very similar lymphodepletion platform, followed by infusion of about 2 million CD19 directed CAR T cells. Now, this trial enrolled about 70 patients. Um, And these patients had a number of high-risk features. Um, Mantle cell lymphoma patients, if their Ki67 or Ki67 is above 50% or 30%, in my opinion, they don't do well. And they had 70% of patients with high Ki67. TP53 mutation in any cancer is bad news. And 20% of patients on this trial had TP53 mutation. All of these patients had seen a BTK inhibitor, typically ibrutinib, and about 70% of patients were actually refractory to a BTK inhibitor. So once you're refractory to BTK inhibitor, historical data from our group and other groups show that patients' median survival is under 6 months. And in this very heavily pre-treated challenging patient population, the response rates with X19 were very high. About 93% of the patients responded, and the complete response rate was 67%. And the toxicity signal in terms of the cytokine release syndrome or the neurological toxicity is very similar to Yescarta because it's a CD28 directed CAR. So the grade 3 rates of neurotoxicity were about 30%, grade 3 or higher CRS was about 15%, identical to what you see with CD19 directed CD28 co-stimulated CARs. And these responses seem to be durable in a number of patients. So the 1-year progression-free survival of mantle cell lymphoma patients getting the ZUMA 2 CAR was about 60%. And after 1 year, there appears to be a tail in the progression-free survival curve indicating that maybe this therapy is curing mantle cell lymphoma patients, but you clearly need longer follow-up. Again, just like diffuse large B-cell lymphoma, even in mantle cell lymphoma, uh, even in mantle cell lymphoma, this is obviously not ZUMA or X19 is obviously not the only CAR. So at the last ASH meeting, the Juno or the JCAR data was presented. It's a smaller subset of 32 patients. Uh, there are differences between this trial and the ZUMA 2 data I just showed you because most of these patients, it's a smaller data set, about the same patient age. The difference here is that not everybody had seen a BTK inhibitor before they went on this trial, and the proportion of BTK refractory patients instead of 80% in the previous trial was about 30% here, but they allowed prior allotransplant. And with these differences in mind, even the Juno CAR looks very active. The response rates are about 84%, and these responses appear to be relatively durable. And activity was seen among blastoid mantle cell lymphomas, TP53 mutated mantle cell lymphomas, and high Ki67. Now, the Juno CAR uses a 4-1BB co-stimulatory domain. And because of that, when you look at the grade 3 CRS rates, they're about 16%. But what's important to see is the grade 3 neurotoxicity rates are about 15%, and they're much lower than what you see uh, with a CD28 co-stimulatory CAR. So that is clinically where the field sits right now. We have 3 CARs approved for patients with relapsed aggressive lymphomas who are refractory to 2 lines of therapy, or any relapsed or refractory mantle cell lymphoma, and we have 1 CAR approved in that setting. But where is the field gonna go? So we will sort of like transition to the next part of our talk. And I think in near future, there are 3 trials ongoing which are comparing the role of auto transplant in relapsing patients. And these trials have a design of uh, they are randomizing patients at the time of relapse to either, if you have a diffuse large B-cell lymphoma patient who has relapsed, ZUMA 7 trial is randomizing patients to either go to CAR directly or get salvage chemotherapy, and if you respond to salvage chemotherapy, get auto transplant. So, so these trials, and it's an important thing people don't realize, are not comparing auto transplant with CAR directly, because auto transplant is only relevant for patients who respond to chemotherapy. Obviously you have big transplant programs in Saudi Arabia. You don't do auto transplants on diffuse large B-cell lymphoma patients who are refractory to chemotherapy. These trials are evaluating the strategy. The question they're asking is, if you relapse, Should you bother with salvage chemotherapy and then doing transplant in responding patients, or should you go directly to CAR? So the ZUMA 2 trial, the ZUMA 7 trial is done enrolling, and the anticipation is that hopefully next year or this year's ASH, we may have readout from this trial. And it's going to be interesting if these trials are positive, then at least in high risk diffuse large B-cell lymphoma patients, maybe you just go directly to CAR instead of worrying about chemotherapy and auto transplant. And there are many downsides on on these trial design that we can talk about later on. Now, if we are looking at CARs in basically second line, is there any data to maybe move the CARs up to front line with first line chemotherapy? Uh, there are clearly lymphoma patients who don't have good prognosis. Lymphoma patients with high IPI scores don't do well. The lymphoma patients with c-MYC gene rearrangement detected by the FISH assay, along with either BCL2 or BCL6 gene, the so-called double hit lymphomas, they obviously don't do well. So ZUMA 12 trial, which was preliminarily presented um, at the last virtual ASH meetings, looked at this question. So ZUMA 12 is a very interesting trial. So the question in ZUMA 12 trial was, if you have these high risk patients, and they defined high risk with either double hit lymphomas or diffuse large B cell with a very high IPI score of more than or equal to 3. Those patients were treated with 2 cycles of R-CHOP, and after 2 cycles of R-CHOP, if these patients still had a Duvel score of 4 or 5, these patients then come off of R-CHOP treatment and go to Yescarta therapy to see if Yescarta can improve their outcomes. Now, 2 things to keep in mind. This is not randomized data. Uh, and half of the patients on this trial had a Duvel score of 4. And my criticism on this trial is that I have seen many diffuse large B-cell lymphoma patients who after 2 cycles of R-CHOP have a Duvel score of 4, which is basically a partial remission, and they get to a CR if you continue R-CHOP. And maybe these Duvel score of 4 patients didn't need to go on CAR therapy. Maybe they would have done better. Duvel 5 is fair game. If you have Duvel 5 after 2 cycles of R-CHOP, continuing it is not going to change anything. So with this massive limitation in mind, doing CAR therapies on these patients was very active. They had very high response rates, but we need to have, this is a setting where you absolutely need to have randomized data to show if CAR is better than continuing the same chemotherapy. So hopefully those randomized data may come down the road, but ZUMA 12 is definitely not going to answer this question. Now, CARs are moving to T-cell lymphomas as well that we will not talk about today, but there is accumulating data with classical Hodgkin lymphoma with CD30 directed CAR. This is some group, this is data from the Baylor and the Chapel Hill group, where they treated heavily pretreated classical Hodgkin lymphoma patients. Now, you can immediately see that the activity of CAR or these PFS curves in Hodgkin lymphoma patients are less flattering than the curves for diffuse large B-cell lymphoma. And they use 2 lymphodepletion platform, either with bendamustine or with fludarabine. Um, all the patients who didn't get fludarabine in lymphodepletion, they all relapsed. Their outcomes were pretty dismal. Patients who got fludarabine in lymphodepletion did better, but the 1-year progression-free survival of these patients is only about 36%. So I think CAR needs a lot of work in classical Hodgkin lymphoma patients because these are young patients. They do well with an allo transplant. You can cure these patients. Um, so, so more work needs to be done here. So, CARs are definitely here to stay. But this is obviously not a perfect therapy. So what are in the last 10 minutes or so, what are the problems with CARs? So, so you may recall that the ZUMA data I just showed you in the beginning, the 2-year progression-free survival with ZUMA was 40%, meaning 60% of the patients after getting CAR still relapsed. So relapse is still a big problem. And some patients, when they relapse with antigen loss, and that may be a reason why patients are failing CAR treatment. Then T cell exhaustion is a problem because you are using an autologous product, and these lymphoma patients, if you keep pounding them with chemotherapies, their T cells get exhausted. And T cell exhaustion is a phenomenon where T cells don't divide well. They don't have very good cytotoxic properties. So if you take a exhausted T cell and make it into a CAR T cell, that CAR T cell is not going to function very well. It's just think about a fresh fighter in a ring versus a beaten up fighter in a ring. Who's going to do a better job? Toxicity is problem. And then we can't get CAR to patients who have rapidly growing diseases. There are patients that I'm sure you have seen who can't wait 3 or 4 weeks to get treatment. So how do we address those patients? Now, this is some very nice data from Dr. Neelapu where they biopsied patients who failed ZUMA therapies. So when ALL patients, and I'm not a ALL doctor, but my understanding is that when ALL patients relapse, a lot of those patients relapse with CD19 negative disease. This also happens in lymphomas, but it is not that common. About 30% of relapsing lymphoma patients after CAR relapse lose CD19. So maybe there is a small subset of patients who fail CAR treatments because the CAR can no longer see the tumor because tumor either does not have CD19 anymore or the CD19 receptor is mutated and the CAR binding site is no longer there. So some people believe that dual antigen targeting, instead of targeting one antigen, targeting two antigens may reduce that problem. And there are many ways of doing dual antigen targeting. So one way is called a bicistronic approach, which the Autolus uh, company called Autolus from UK is doing. So bicistronic means you have two different CARs on the same cancer or the same T cell shown in the top right corner. The other approach is called a tandem approach, where your single CAR targets two molecules. And this is something our group has been doing for a long time, and I will share some data with you. Or you can put two independent CARs in, which is called co-administration. So our group went the route of doing a tandem CAR. So we produce CAR T cells using a Prodigy device in-house, where we are producing CD19, CD20 tandem CAR. So the same CAR molecule targets CD19 and 20. And this platform is using a 4-1BB co-stimulatory molecule. So we don't see a lot of CRS or CRES. This is a CAR you can administer on an outpatient basis for some patients. And our initial experience that was published recently shows that this platform is active, and we have a number of patients now with very durable complete remissions. Now we have patients who have relapsed, and interestingly, none of our relapsing patients have lost either CD19 or CD20. So I just showed you these data just to show you as a proof of concept that maybe instead of single antigen targeting, if you target dual antigen, then maybe antigen escape may not be a problem, but we clearly need more data. The other problem is tumor T cell exhaustion. If you get T cells from a patient who is already beaten up, their T cells might not be very high quality T cells. And there is some proof of this concept now. So remember, ZUMA 1 trial enrolled patients with very heavily pretreated disease, and the ZUMA 2 trial, ZUMA 12 trial was patients who were given CAR after only 2 cycles of R-CHOP. And when they looked at the T cell profile of these two trials, the ZUMA 12 trial, where patients had gotten very little chemotherapy, in these patients, the proportion of CCR7 positive, CCR45RA positive cells was much higher. And this is a profile of less exhausted T cells. So there is some, at least, hypothesis that if you apply CARs early, you may get better quality T cells and they may perform better. So that may be a reason to move CARs to an earlier line of therapy. The third issue is our toxicity. Uh, Although CRS and CRES are typically not fatal, but it is a management challenge. So ZUMA uh, one trial has an exploratory arm, uh, where tocilizumab was preemptively given for patients with early signs of CRS. And with that strategy, the CARs appear to be as effective, uh, but the rates of severe CRS and neurotoxicity come down. We clearly need more data, but there are many centers in USA who are using this strategy clinically already, where tocilizumab, we don't wait for patients to develop grade 3 CRS. We are giving it at maybe grade 2 or persistent grade 1 CRS now, just to prevent development of severe grades of CRS. The third challenge, or the fourth challenge we have is, when CARs came out, CARs were the only CD19 therapy out there. But now we have, at least in USA, we have one commercially available CD19 therapy called tafasitamab, which is a CD19 antibody. And our group has worked a lot with a CD19 drug antibody conjugate called Lonca, which we hope will get approval this year. So do CD19 CARs work if you have gotten a CD19 directed antibody or drug antibody conjugate previously? So there is some mouse model that CARs directed against CD19 work after tafasitamab administration, and we published our experience of giving CARs after ADCT therapy and CARs working after getting a CD19 antibody conjugate. So I wanted to mention it because a lot of people say if you get a CD19 antibody, CARs after that will not work, or if you get CARs, you shouldn't get a CD19 antibody afterwards because that will not work. And at least in our experience, this is not true. I have given CD19 antibodies before CAR and the CARs worked, and the other way around too. The next issue is we are now dealing with, if the CAR fails and you can't control the disease, should you do CAR again? And the answer is I don't know. But there is some very nice data from the Seattle group where Jordan Gauthier looked at CAR after CAR infusion. So people with CLL or follicular lymphoma or non-Hodgkin lymphoma who relapsed were given a second CAR infusion. And it doesn't work for most people, but for whatever reason, if you use fludarabine containing lymphodepletion, about 30% of patients or 25% of patients respond with a second CAR infusion. Now, the limitation here is that these patients are getting CD19 CAR after failing CD19 CAR. In our experience, we have given our CD19-20 tandem CAR after failing CD19 CAR. At least in our experience, it doesn't work. We don't have a single patient who had long-term remissions. So I'm not a big believer of CAR after CAR strategy, at least using autologous CAR T cells. Um, then we need to do a better job of identifying patients who don't do well with CAR therapies. So over the years, we have started to identify patient factors where CARs may not do very well. So patients with very high inflammatory markers like high baseline ferritins or high baseline CRPs don't do well with CAR treatments. Patients with high LDH don't do well with CAR treatments. Patients with high metabolic volume or bulky disease, unlike the initial publications, don't do well with CAR therapies. So we need to learn about, if somebody has bulky disease, should those patients be debulked before you give them CAR treatment? Should you need better disease control before you get to CARs? So we need to define patients who are likely to fail CAR treatments, maybe to design post-CAR treatment maintenance strategies. And our group at BMT is starting to look at this question as well. And then I guess the area of the CAR T cells in my final one or two slides that will grow in the coming years is going to be off the shelf or allogenic CAR T cells. And believe it or not, there are a number of platforms already out there. There are many advantages of a allogenic CAR platform. Number one, uh, you can just get that CAR immediately so that your patients don't have to wait for apheresis, transfection, then the cells to come back. So in theory, if there is a commercially available off-the-shelf CAR, you can just get the CAR and infuse the patient within a week. The second advantage is these cells are either coming from umbilical cord blood or healthy donors. So hopefully these T cells are not going to be exhausted. Maybe they will work better. The downsides of these allocars are that these allocars may not engraft because your body can reject these allocars. So there are many platforms out there, but just to give you a flavor of it, I'm going to show you two platforms. So the first platform is called the allogene platform. So it's an interesting platform where through gene editing, they first edit out. So when they make their CAR, they take the T cell receptor out so that these cells can't cause graft versus host disease. Then they take the CD52 receptor out, and there is a reason for that. So the CAR that they are making is directed against whatever antigen, BCMA for myeloma patients or CD19 for lymphoma patients. So they do the transfection and then they take out the T cell receptor to prevent graft versus host disease and take out the CD52 receptor. And they give lymphodepletion with fludarabine cyclophosphamide and a Campath-like drug. So you're basically eliminating the CAR rejecting cells in the patient. But since the CAR doesn't have CD52, Campath doesn't kill those cells. And that's how you infuse the allogenic CAR and hope it persists. Uh, this strategy is active in lymphomas as well as myelomas. The problem is because of this Campath administration, we are now starting to see a number of viral reactivation problems, and they are not easy to manage. So you're seeing a lot of CMV and lethal adenoviral infections. But that's one strategy. The second strategy is in my opinion really cool. So you're familiar with the European work on alpha beta depleted transplants to reduce graft versus host disease, which CARDIS has done a lot of work on. And the concept is if you deplete alpha beta T cells from an allogenic transplant, you are infusing only gamma delta T cells, which don't cause graft versus host disease or rejection. And this principle is being used by a company called Adicet. So they're actually purifying gamma delta T cells from healthy donors, cells that shouldn't cause graft versus host disease. And these are innate immune system cells. And then they are basically transfecting these cells with a CD20, CD19 CAR, and then hoping to administer this CAR. So this is a trial, phase 1 trial that we are hoping to open. No humans have been dosed with this strategy so far, but there are certain advantages of this gamma delta CAR because obviously the CAR portion recognizes the cancer, and gamma delta T cells are innate immune cells. So they have anti-cancer properties on their own, even if they are not converted to CAR T cells. Gamma delta T cells home very well on tumors. They are not likely to cause uh, graft versus host disease, um, and and it has all the other benefits of being an allogenic CAR. So a lot of things that we need to learn, and our field is rapidly changing. So where are we going from last year to now? CARs are obviously moving earlier into therapy lines. We need to identify patients who are likely to relapse after CAR T cells so that we can think about other strategies for those patients that may include post-CAR maintenance treatments. There are a lot of BiTE or T cell redirecting therapies coming out at the last ASH meeting. There was a lot of data with BiTEs. So are BiTEs better than CARs or CARs better than BiTEs? It's an ongoing debate. BiTEs are obviously easier to give. CAR failures is a big problem. Most of the patients who fail CAR don't do well. And then the big question is future BiTEs, and if our future is CARs, which CAR is better? Is autologous CAR better or the allo CAR gonna win eventually? My guess is if the allo strategy could be figured out, um, that may be the future. So I'm gonna stop here. I'm gonna acknowledge these um, colleagues who shared their slides with me over the years. And I want to acknowledge their work. And I'm gonna stop here and happy to take any questions.
Thank you so much, Dr. Hamadani, for this interesting talk. Very well organized and informative. We have a couple of questions. The first one is asking about why do you think that bites are not commonly used yet for CAR T compared to CAR T and lymphoma?
Only because they are not approved, right? Uh, so bites are challenging, right? So there are um, when we think about, I can talk about at least the US practice, right? So I think bites are very relevant. I have patients who have durable responses even with myeloma with bite therapies. We have more experience with bites and myeloma in our program than with lymphomas. But there are obviously patients who have durable responses with bites. Bites, you don't have to go through all the problems with FACT and JC. So you obviously, once you have a commercially approved bite product, the next thing you need to know is how durable the responses are, right? So if we don't have, that's kind of a long-term follow-up on bites to see if it is really curing the patients. Mosunetuzumab is arguably the only bite where you have long-term follow-up, and their tails of their curves don't look very flattering. But the way I think about, in lymphomas in the coming years, the three big players are going to be antibody drug conjugates or ADC, and Lonca will get approval, bites, and CARs. And the way things will turn out is in private practices, people will give either Lonca or tafasitamab. If that fails, patients are going to be referred to academic centers. And in USA, unfortunately, academic centers are either lymphoma non-transplant programs or transplant programs. And my guess is if a patient ends up in a transplant program, they're going to get CAR. If they end up in a non-transplant group, they're going to get BITE. And once they fail one treatment, they'll cross over to the other one. But obviously, there is no head-to-head data to figure out which one is better.
Thank you. The other question we have is, are you aware for any studies linking CAR T and TRex, and if the initial levels of the TRex can influence the CAR T treatment?
Not to my knowledge. So sort of the CAR constructs, and they're like, there is so much activity in CAR platforms. Um, it's hard to say with confidence that there is. I can't say with confidence that there is no CAR and TREC combination out there. I'm aware of the TRuCs that I mentioned. TRuC is a concept of adding the CAR receptor to the T cell receptor, and all the benefit of the downside of CAR is, you are relying on an unnatural co-stimulatory structure, right? When you bind the CAR to the T cell receptor, then the whole T cell receptor signals. So it has benefits of persistence, better anti-tumor responses, and then the two allo sort of platforms I showed you. But I'm not aware of a CAR conjugated to T regulatory T cells or CAR being administered with Treg cells. There are CAR platforms that are using IL-2 in low doses. The concept there is to not to rely on Treg activity, but to expand the CAR cells because of IL-2 administration.
Okay, thank you. We have another question. If the patient needs steroids, in your opinion, let's say a year post CAR T, what would be your strategy and doses, keeping in mind that the CAR T could be affected?
So it's a very good question, right? So a year post for a patient who's in remission, I probably wouldn't worry about it, right? So generally, if you're a year out and if you have not relapsed, you're probably cured. And you don't necessarily need persistence for cure, right? So think about a CAR like Yescarta. We have the ability to track Yescarta, and Yescarta basically, once you give it, it doesn't persist more than 1 or 2 months. And those patients are, like if you look at the 2-year PFS, it's 40% with a CAR that doesn't persist. So I don't think persistence is what you need for cure. Kymriah persists longer, uh, but after a year, I wouldn't worry about it. But early steroid administration is problematic, right? So I didn't think it was a big issue unless just coincidentally last week there was a paper either in Blood or Blood Advances by Dr. Saira Ahmad from the MD Anderson Cancer Center. So with Satwa Neelapu and Saira, they looked at cumulative steroid doses early after CAR, and they clearly show that higher the dose of steroids you get, inferior is the survival and higher is the relapse rate. So steroids clearly do kill your CARs and make them less efficacious. So I would worry more about it early on. A year out, probably not.
Okay, thank you. We have so many interesting questions. I think you touched based on this. One question is about what do you think the future will be for a patient who has primary refractory diffuse large B-cell lymphoma who failed upfront R-CHOP, and we know that these patients don't do well.
Yeah, so most of these patients absolutely don't do well, right? So anecdotally, we just had a paper in BBMT from CIBMTR where we looked at primary refractory diffuse large B-cell lymphomas who happen to respond to next line. And full disclosure, most primary refractory patients will not respond to the next line. But if they do, and you don't have CAR T cells, you can still cure these patients, maybe a small subset, maybe 30-35% of those patients with an autologous transplant. So while the new better treatments are coming, cooler treatments are coming, don't forget about the old autologous transplant. If used at the right time, it is still very useful. But once we have the results of ZUMA 7 trial. So ZUMA 7 trial enrolled diffuse large B-cell lymphoma patients who were either primary refractory or relapse within a year. That's another important thing to remember. ZUMA 7 does not apply to patients who relapse late, but patients who relapse within a year. And if the ZUMA 7 trial is positive, which I suspect it will be, for those patients, if a CAR therapy is available, the standard would be to give them CAR treatment. Now, another thing to keep in mind is that the ZUMA 7 trial randomized patients to CAR without salvage or salvage followed by auto if the salvage worked. What will happen in real life is most of these lymphoma patients don't live in academic centers, at least in USA, right? So if an aggressive lymphoma patient relapses after 8 months, my referring oncologist will start them on RICE treatment and they will send those patients to me after they've gotten 2 cycles of RICE. And if they are in CR, am I going to give them CAR or an auto? Regardless of what the ZUMA 7 results are, I'm going to give them an auto. Even if they are in a partial remission, I would argue that I would still give them an auto because we just published a paper in Blood in the last couple of months where auto cures about 50% of patients who get auto in a partial remission. Uh, but if I happen to see a patient who has just relapsed and hasn't gotten a therapy and ZUMA 7 is positive in favor of CAR, I will do CAR. But the real life may act a little differently.
Okay, thank you. We have maybe one more question. How can we make sure that the number of cells are infused correctly, and that's what the patient needs for CAR T therapy?
So we don't know, right? So I can tell you that in our internal experience, when we do our own CD19 20 CAR on a trial, two things are very important. Uh, the cell dose is very important. Uh, our CAR didn't work very well for patients who didn't get a good dose. Um, you need about 2.5 million cells. And in our hand, fresh CAR rather than frozen cells or cryopreserved cells. Fresh CAR worked better. The problem with commercial cars is we don't know the dose that is coming in, right? So the bag doesn't have a dose written on it. So all we know is that this product has passed the QC parameters. For example, for Tecartus, the QC parameter is about 2 million cells. So if it passes the parameter, you assume that the dose is right, but the dose is not given to us on a commercial product.
Okay, thank you. Another question about the treatment of CRS with early steroids. Do you think that could affect the efficacy of CAR T? If yes, how many days?
Yeah, so early CRS, we would treat it with tocilizumab, not with steroids, just because of tocilizumab is, that's where the label of tocilizumab is, right? And you want to avoid steroids early on. Um, you the situation where you have to use steroids is obviously neurotoxicity. Somebody who develops um, severe enough neurotoxicity where you need to give steroids, or a CRS that is not responding to steroids, not responding to tocilizumab, then we give corticosteroids. The problem with something like Yescarta is that CRS happens early, right? It happens within, like, the median time to onset is about 3 days. And if tocilizumab doesn't work, you have to give them then steroids. So you really don't have any other options. Having said that, Insight has a trial open, and it's open at our site as well. They're prophylactically giving Jakafi to reduce the probability of developing CRS. So we'll see if that strategy uh, is useful or not. But when we give steroids, we try to give it as small a dose as possible and as shorter a time as possible. But there is, like, I can't tell you that you shouldn't do it within the first 7 days, because if you have to do it, you have to do it, right? Um, so my word would be use the lowest dose possible for the shortest period of time possible.
Thank you. We have some other questions. And this actually good question about cytopenias post-CAR T, mainly neutropenia. What do you think could be the cause, and what do you think about using G-CSF for these patients who need for neutropenia?
So very good question, right? So we don't know why cytopenias happen, um, but it happens with like I don't think CD19 is expressed on stem cells, but you see uh, cytopenias because of rituximab as well. Uh, the question is, what do you do with these cases? So the interesting thing about CARs is that these cytopenias, you won't see much in the first, I would say, 2 or 3 weeks. They tend to happen late. So with late, I mean it will happen maybe in the third week or the fourth week, they become neutropenic or thrombocytopenic. Uh, I'm comfortable giving somebody Neupogen after, I would say, 3 weeks or so. There are some concerns that if you give growth factors, GM-CSF probably more than G-CSF, that you can trigger cytokine release syndrome. But after 3 weeks, we do give Neupogen. I've not seen any CRS happen. I have never given Neulasta, the long-acting or the pegfilgrastim, to these patients. So we give a dose of Neupogen, see what happens. Most patients eventually respond. I don't know if they respond to Neupogen or the counts recover on their own. But there is definitely a subset of patients who have prolonged uh, neutropenias or thrombocytopenias. And while it is not on label, there are anecdotal reports, and I have maybe one patient that responded to Promacta. So we tend to think of it like an autoimmune process, and Promacta uh, or the thrombopoietic agents are obviously approved for treatment of aplastic anemia in addition to ITP. So there is some data out there that you can use that, and I've seen one patient respond. So that's another trick to keep in mind. And steroids sometimes help too.
Okay, thank you. Here we have a question about CNS positive disease. What's your experience with infusing CAR T with CNS positive disease? And any your toxicity expected to be more, but what has been your experience?
So another excellent question. So when you talk about CNS, there are two categories, right? Primary CNS lymphomas or lymphoma secondarily, maybe a diffuse large B cell that relapsed into CNS. I'm not aware of any data in patients with primary CNS lymphomas, but I'm sure you have seen the report from the Mass General Group by Dr. Eben Chen, and Jeremy Abramson, who published their series of, I think, 5 or 6 patients in blood using Kymriah in secondary CNS lymphoma patients, and it wasn't really associated with enhanced neurotoxicity. We are writing up our experience at the Medical College of Wisconsin. We have treated 6 patients, all with secondary CNS lymphomas, not with primary CNS lymphomas. And 2 patients got Yescarta, 4 patients got Kymriah, and they have done well. 2 patients relapsed, but we didn't see any excess neurotoxicity, right? So I think in your programs, once you have experience with treating typical patients, there are no undue toxicities in patients with uh, sort of like CNS involvement. But one limitation is I have not treated anybody with with a big brain mass, right? So these patients had parenchymal disease, but not big masses, or leptomeningeal disease, meaning their CSF was positive. So I can't extrapolate those data with maybe a 3 centimeter mass sitting in the brainstem. So
Okay, thank you. Unfortunately, we have to end the session. We have too many questions, but thank you very much for this excellent talk, interesting question and session. So thank you very much, Dr. Hamadani, for this.
oh, thank you, and thank you for your kind invite. So it's like giving talk to friends.
We're looking forward to have CAR T practice more in Saudi Arabia to do an experience. So thank you again, and we would like to thank again our sponsor for tonight's webinar for CAR T, the SSBMT. And we would like to remind you about our next webinars. So it's going to be on Saturday, the 13th of February, 2021. It's going to be about how I treat fungal infections in the HSCT setting. And the other one will be about how I treat chronic lymphocytic leukemia. So I will recommend that you join us for our next webinar. Thanks everyone for your patience, and I hope that everyone enjoyed the session, and we look forward for the next session. Thank you all.
Thank you, Abdullah and Mehdi. Great talks.
Thank you, Dr. Alaskar and Al Saleh. Assalamu alaikum.
Assalamu alaikum.
Bye-bye.
Bye.